Chapter 7, Part 2, the skeletal system. We're going to pick up where we left off with Part 1, where we focused mainly on the cranium, the bones of the facial aspect of the cranium, the vertebrae. Now we're going to focus on and for Part 2, we'll focus on the ribs, the costals, and the portions of the appendicular skeleton, so your appendages. When we look at the ribs here, you see you have the sternum and the costals or the ribs. So let's begin here with the sternum. Three major parts to the sternum. You have your sternal, you have your mambrium here that includes this upper portion, kind of like a heart shaped up top here, that has your suprasternal notch. You have the clavicular notches here where the clavicles are going to articulate with here, make up this whole pectoral girdle or this upper arm shoulder area. So your mambrium, that first part of the top portion of the sternum. Then you have the main body here, which is the largest part of the sternum, and it is where ribs are going to attach. And then you have your xiphoid process, which is the most inferior portion of the sternum, and it is a pointed bony process where you have other abdominal muscles attach here. When we look at the ribs, notice how you have, also here in this diagram, you have your rib cage that consists of 12 pairs. You have what's known as true ribs, the vertebral sternal ribs, and they're called that, the first 7, because they attach directly to the sternum and the vertebral column. Okay, so your T1 through T7. Then you have what's known as the vertebral chondral ribs. These are your false ribs, chondro meaning cartilage, because they're going to attach first to cartilage and then to a cartilage again to attach to the sternum. Okay, they don't attach to the sternum directly. They go to cartilage first and then the sternum. And then lastly, you have your false ribs, or excuse me, incorrect, your floating ribs. Okay, that are mainly there that they lack attachment to the sternum. So they are attached to the vertebral column, but they are not attached to the sternum. So therefore they are floating. When we look at what an individual costal looks like, you see here you have the back side here. And how do we know that this is the back side of a costal? Because we see the facets where they're going to articulate with the vertebrae. So you see your superior and inferior articulation vertebral facets, and you see your transverse process, your tubercle here that's going to articulate with the transverse process of the vertebrae. And then here and these are bumpy. Okay, you can usually tell that that's the bumpy end. And then a smoother end, this junction here with costal cartilage that's going to attach pretty easily, okay, and smoothly here with the sternum. Looking at the whole pectoral girdle here, you see the pectoral girdle includes the clavicle and the scapula, and that term girdle simply means to surround or encirculate. So they support the upper limb and specifically the humerus, and it's an attachment point for numerous muscles. So let's look at the pectoral girdle a little bit more detail here. You see the clavicle has a sternal end, a more flat end, and an acromial end that's going to articulate here with this acromioclavicular joint, this more anterior curved portion of the scapula that's going to curve more inward. You see how it fits kind of nestled in there. It attaches here to the mambrium of the sternum and attaches here at this acromioclavicular joint of the scapula. Okay, speaking of the scapula, you see here its location, this anterior view here, how the clavicle fits closely in there. You have the humeral head It's going to articulate here with the glenoid fossa of the scapula, which we'll look at here in a minute, and how the scapula is both a posterior bone and an anterior bone ever so slightly, because of the coracoid process here. So let's look at that in a little bit more detail. I love this slide because if you study it, you'll be able to clearly understand how to tell the front, the side from the back of the scapula based on these bony processes. So let's look at that. The scapula is a triangular bone that sits in the post-supral region of the rib cage and extends, there I said, partly anteriorly here with the acromion process and the coracoid process, and then also posteriorly. Okay, the most of it's on or you see here where it's this part is anterior, this part is posterior. Okay, right here. So it's unique in that aspect. You see that we spoke about earlier here, the coracoid process, that is going to be that articulation point here, along with the glenoid fossa or glenoid cavity here of that humeral head. And you see the suprascapular fossa here of the scapula and this inferior angle that is unique to the scapula. When you look at the lateral view here, you see that glenoid cavity, that acromion curve we spoke about, and that coracoid process. And then the unique features of the posterior aspect of the scapula is you have the spine, the scapular spine here, and that supraspinosum fossa and that infraspinosum fossa. That's going to be the articulation point for a lot of your, or excuse me, origination point of a lot of your rotator cuff muscles. It's a pretty interesting shaped bone. When we look at the humerus, okay, it is the largest bone of the upper limbs, and it makes up the brachial aspect of the body. So brachio means upper arm, okay, the brachial pulse. So remember that term, I think back from chapter 2. You have some interesting features of the humerus. Let's look at the anterior view here, the front view. You have the humeral head. You have the greater tubercle here of the humerus, separated by a lesser tubercle. You have the deltoid tuberosity here, which, as its name implies, as its name has, it's the attachment point for the deltoid muscle. And when you look here, also what's known as the surgical neck. Well, that's more of a posterior view, but right around in here, it's known as the surgical neck, because this is the frequent site of fractures that oftentimes require surgical fixation or surgical repair, because it is in between the two epiphyses. Okay, your proximal epiphyses and your diaphyses here. So it's a unique area known as the surgical neck. When we look at the distal epiphyses here of the humerus, you see these articulation points with the radius and ulna. The lateral epicondyle here, which is the site of muscular attachment. Okay, a lot of muscular attachment here. You see the coronoid fossa, which is that indention here, this small indention that's going to allow for that hinge joint movement of the elbow, your medial epicondyle here, okay, and the trochlea, or also known as the wheel, but the trochlea named for its shape, which resembles a wheel or spool of thread, that allows for that ease of motion for that hinge joint we spoke about here earlier. Here's a posterior view of the humerus, the distal epiphyses. You have this olecranon fossa here, where you're going to have that hook portion, the olecranon of the ulna that's going to hinge here. Okay, and then your medial and lateral epicondyle as well. When we look at the bones of the forearm, okay, so the lower arm, they consist of two bones. You have your, let's look at the anterior view first. Here you see that trochlear notch of the olecranon we spoke about earlier. That allows for that hinge motion. The radius here, this radial notch, allows for that supination, pronation of the palms, so palms up, palms down. That rotation of the palms is thanks here to the radius, the radial head, this flattened portion here. So those are two unique features of the radius and ulna that are pretty easy to distinguish proximal end and distal end of the radius and ulna once you understand those two features. You have the radius and ulna that are kind of fused together here by this intraosseous membrane. Inter meaning between, osseo meaning bones. This interosseous membrane distributes force between these two bones to kind of make them equal in reducing the load on each bone. So it helps to kind of distribute the force there. And then, which leads us down here to the distal ends of the radius and ulna. Notice how, yes, they both have the stylus processes here that's going to help them articulate with particular bones of the carpals. So you have your radial styloid process here and your ulnar styloid process here that are going to aid or join up, or going to articulate with the bones of the wrists, specifically the lunate and the scaphoid. So let's take a look at that next. Okay, this is the posterior aspect. Okay, notice how the hook here is going to be on the anterior. Okay. Radius is always thumb side in anatomic position. Very important to remember. And you see here that trochlear notch here that allows for that hinge motion of the elbow. Pretty fun part of the anatomy. There's that radial head we spoke about that allows that supination, pronation movement of the hand. Speaking of the hands, here we go. So you see here the ulnar styloid process that's going to articulate with the lunate, and the radial styloid process here that'll articulate with the scaphoid, which are your carpals. Okay, you see here your bones of the carpals that make up your wrist. So you may have heard of the disease, what is it called? A carpal tunnel syndrome. This is where it comes from, where the bones of the carpals, the bones of the wrists, have become, notice how it narrows here, and it can lead to nerve damage. Okay. Moving on, you have the metacarpals, meta meaning next to. These are the bones of the hands, the five long bones of the palms of the hands. Each metacarpal consists of three parts. Okay, your proximal epiphysis, your diaphysis, and your distal epiphysis. So just like any long bone we've been speaking about. And notice how they are numbered. In anatomic position, the thumb is always digit number 1. Thumb is also known as your pollex, where your big toe is known as your hallux. So your pollex is always digit number 1. And it has its own name because of its own unique feature. Your pollex and hallux, your thumb and your big toe, only have a proximal and distal phalange. They do not have a medial phalange like digits 2 through 5 do, sinister, dexter do, or have. So it's important to remember that. So notice how you have a proximal and distal phalange here of your pollex, digit number 1, how you have a proximal, middle, distal phalange here of digit number 2, and so forth and so on. So say I accidentally broke, okay, this bone right here. Okay, how would you describe that, excluding the type of fracture? We're not going to talk about that, but how would you describe that bone, right? Oh, correct. So It would be middle phalange of digit number 4. Okay. Whereas this is um, proximal phalange of the pollex or digit 1. All right. If the break was here on 5, it would be metacarpal 5, and so forth and so on. So it gets very specific when we talk about medical terminology. You see some more internal detail here of the exact carpals and the numbering of the metacarpals. Let's move on now to the, this is a good picture here of wrist fractures. Okay, so you see the fracture here of the distal ulna. I am not a radiologist by any means, so I barely know how to read x-rays, but they are kind of fun to kind of see the internal, to see the actual bone structures here. Okay, but that indention right there should not be there. Okay, moving on to the pelvic girdle. Okay, bones of the pelvic girdle and lower limbs. You see here your pelvis, which is made up of the sacrum, the coccyx, and the coax bones, which make up the pelvis. Okay, you see this pelvic inlet here, which is the opening that is formed when all the bones are fused together, and then you see the pelvic brim here. So let's look at some of the more specific features here of an articulated pelvis. So you see the sacrum and the coccyx, which we spoke about in part 1. You see here the iliac fossa and the iliac crest here that are a type of flat bone, and the iliac spine that, or the superior, excuse me, iliac spine, which has a small projection, and this greater sciatic notch. Yeah, the sciatic notch here. I was going to see a better picture. Yeah, right here. This is the one I'm looking for. The greater sciatic notch here that allows that sciatic nerve to go through. Okay. Have your ischium here, your ischial rami. The ischium here, also known as the your sits bone. Okay, when they say to sit back on your sits bones, these are the ones you're sitting on here. And where the two pelvic sides, two pelvic bones join together is here at the pubic arch, or the which is also known as, or this arc here, this curved area, and it's joined together by this cartilaginous joint here known as the pubic symphysis. We won't talk a lot about the differences between a male and female pelvis, but there are some distinguishing differences here. Goes in more to forensic medicine, but it is pretty interesting how the biological differences here between the actual bony structures and characteristics of the pelvis. The female, the wider, more broader pelvic inlet here compared to a male, the wider stance here of the greater pelvic girdle itself compared to the male, and then the overall height, okay, of the male, excuse me, the male pelvis compared to the female pelvis, and also the what we spoke about earlier, this pubic arch here is wider in female than compared to male. When we look at the femur, okay, the largest long bone in the body, the femur, or the largest and strongest bone, you see the femoral head here, the greater trochanter notch here, which is the major attachment point for a lot of gluteal and hip muscles, which we'll talk about more in the muscle chapter. You see the lesser trochanter here. You see the spine here of the femur, the proximal ends, and then the distal ends here you see where they will articulate here with the knee. Let me show you here. Yeah, anterior view. So You see the medial and lateral epicondyle here. The femoral head obviously is always going to be medial. The greater trochanter is always going to be lateral. And uh, you see the patellar surface here that allows for that gliding of the patella, that bone that's going to articulate with the femur's patellar surface here. Let's look at the posterior view here. You see this intercondylar fossa here. Okay. And the lateral and medial condyles here, very important with that flexion and extension of the knee. Wish your book, excuse me, showed a picture of the knee in flexion. So you can actually see how this smoothed condyle surface aids in that movement. Pretty interesting to see. Then you see the patella here. This is an anterior view of the patella. You can always tell superior from inferior because the apex here of the patella will always be inferior. And you can always tell anterior from posterior because the anterior portion is always going to be more rounded, where the posterior portion is going to have these internal facets, okay, a medial and lateral facet that articulates here with the greater and lesser condyles of the distal femur. Excuse me. What did I say? The lateral and medial condyles of the distal end of the femur. Forgive me if I said something different there. Then we're moving on down to the shin bones or your tibia and fibula here. Okay, the two bones that make up the lower leg, the medial tibia and the lateral fibula. Okay, tibia. Students do get these mixed up a lot. Remember, the fibula is always lateral. The fibula is always the smaller of the two. Okay, so that's kind of how I remember them. The tibia itself, let's do this anterior view, is large. It has this anterior crest here, which is why when you get hit with the shin in the lower leg, when you get hit in the shin, there's a nerve that runs right down this crest here that can really hurt when you get hit in the shin right here, when you get hit on this anterior crest of the tibia. You see here the medial and lateral condyles of the tibia. You see the tuberosity here of the tibia that is the patellar ligaments are going to attach to right here. So your kneecap ligaments are going to attach the kneecap in place here to this tibial tuberosity. And just like in the forearm of the radius and ulna, you have the interosseous membrane here of the lower leg that's also going to aid in distributing that weight of the lower leg. But remember, the tibia is the one that's going to carry the majority of that weight. Come on, little man. And your fibula is simply there to act as a stabilizer for the ankle and more of a balancer, whereas the tibia is the one that is responsible for bearing the body weight on the lower leg there. Okay, let's look at the posterior view here. You see the head of the fibula is not necessarily a styloid-like process like the distal aspect is, but and it's more of a malleolus than a stylist. But notice how the anterior aspect, or excuse me, the proximal end of the fibula head is more rounded, whereas the lateral malleolus area is more pointed. All right, moving on down to the feet. All right, so the structures of the ankles parallel that of the wrists, which we've already talked about. The ankles consists of several of these short bones known as tarsals. Okay, here's a good anterior view here. Your talus, the navicular, the cuboid, and the medial, intermediate, and lateral cuneiform bones of the ankle make up your tarsals. Okay, and just like the bones of the hands, you have a first, second, third, fourth metatarsal. And also, just like the bones of the hands, the hallux is the big toe, similar to the thumb in the fact that it only has a proximal and distal phalange, does not have a medial phalange like your second digit does, third, fourth, and fifth digit have medial phalanges. Your big toe does not. So something to consider there. When we look at the lateral view here of the foot, man, oh man, if I had to leave you guys with one thing in relation to your feet is please take care of your feet, okay? Um, there are a lot of issues that can go wrong with your feet structurally, tendons, muscles. So put your money into good quality shoes that are going to protect your feet and support your feet and also take care of your feet as far as circulation goes and vasculature goes. In my clinical practice as a dietitian over the years, I have seen people's lives be devastated by injury, whether it be vasculature wise or musculoskeletal wise to their feet. And it really, we take our feet for granted. Okay. So please keep that in mind. Take good care of your feet. And they are pretty interesting anatomically. You see here the different arches of your feet, and this is why it can be so complicated and why shoes are so important to make sure you have that full support for your feet. Okay. Please let me know if you have any questions or concerns. This concludes the lecture videos for Chapter 7.